Hey guys, how you doing? Okay, so let's go ahead and get started here. We're going to try and finish up this chapter 29 as far as lectures are concerned. Um, Assessment and care. Emergency medical care. Remove the patient from the source of the burn and stop the burn process. Do not remove adherent materials from the burn. As I'm talking about, things are going to get adhered to the skin. I'm cutting off clothing or something and it's stuck to the skin, leave it in place. Brush away dry powders before flushing and remove smoldering clothing if there is any. Basically, they're using an IV bag here to begin to cool off the wound. Remember, the best way to cool off any injury is water. Okay, in this case, saline. We have sterile bottles of water as well. This guy has burned to his knee, obviously. Exposing that area, remove any smoldering clothing so we can see how bad this injury actually is. Emergency medical care, maintain an open airway, adequate breathing and oxygenation. Make sure to give them oxygen. This is a benefit for them. Positive pressure ventilation for inadequate breathing. We're going to breathe for them. Remember, this is going to be something that's really going to affect their lungs and their breathing capacity. Administer oxygen by non-rebreather for toxic inhalation and maintain an SpO2 of 94 or above. And that's something we understand now directly. SpO2s need to be 94 or above. Classify the severity of the burn, taking into account the BSA, source of the burn, location of the burn, patient's age, pre-existing medical condition, transport patient with critical burns immediately. Again, that BSA body surface area is the percentage of or rule of nines, as you saw on the worksheet, or the Palmer method, making sure that we identify the exact percentage of burn depending on first, second, third. Actually, we're talking second and third degree burns. Certain percentage of the body being burned between second and third degree will dictate is this a trauma center or excuse me a burn center patient or not. And I always think it's better to over estimate the percentage of burn. Not crazy. I mean, if they got a small little 1% process of the burn on their body and you call it 15%, that's ridiculous. If you're looking at for that third degree burn, you're looking at 15% of their body burned, and you can identify about 12 to possibly 15%, make it 15%, give them the care they need. Cover the burn area with dry sterile dressing, burn sheet, or approved commercial dressing. Excuse me. Moist dressings can lead to hypothermia. So want to be careful how much water we put on, but it still is important to do this. Some systems allow moist dressing with less than 10% of the body BSA, body surface area burned. Follow local protocols, and you'll get all that when you get out there. So basically, cover with a dry sterile dressing. I'm going to tell you something, guys, and I'm going to be honest with you. Book work and things we learn in the field. We here in Southern California are so close to care facilities that it's a good idea to keep a moist dressing under that dry dressing. Okay, and here's the reason why. When you put on a dry dressing over that burn, you've done everything you can. You've cooled the area off. Good job. You now actually put dry dressing on top and wrap it in place, and you're doing exactly what you're supposed to do. But the problem is when the ER tech or the nurse actually begins taking everything off, they're going to begin to pull skin off again because that dressing is going to adhere to that burn. So in this respect, it's a better idea to, especially a small one like this, is to place a wet sterile dressing on the injury, place a dry over that, and then wrap it in place. This prevents the skin from actually adhering too much to the gauze bandage, and we can work it better later. Keep the patient warm, treat other injuries if there are any, transport to the appropriate facility as soon as possible. Avoid using materials that leave particles. Our sterile dressings, our roll gauze bandages actually should prevent that for the most part. Leave applied ointment, lotions, or antiseptics to the burn. Excuse me, never apply. You're going to open up most first aid kits and find burn creams. Don't use them. They don't work. There's reasons for them for minor burns, but for severe burns, this just traps the heat in. We don't want that. Okay, we want to make sure the heat comes out one more time. Water, water, water. It's the best thing we can use. Never break or drain blisters, as I was saying. Burns for hands and feet. Remove jewelry, like we were talking about. Separate the digits. with dry dressing or gauze. Again, if the digits, fingers and toes are actually pushed against each other, that's going to also adhere to each other. And when you pull them apart, skin's going to come loose. So we want to make sure we cover that. And again, we're located close enough. I think it's a better idea to have wet to dry in these types of dressings. It's local protocol kind of thing. And again, if we do too much wet to dry, yeah, we're looking at hypothermia patients. But if it's a small area and we're close to the hospital, let's go ahead and keep them wet because we don't want that skin to stick to the gauze also. Burns to the eyes, do not attempt to open the eyelids. For thermal burns, apply dry, sterile dressings to both eyes, and for commercial burns, flush with water. So we want to make sure we're flushing those eyes completely. You'll see a little clip of that here in a while. Reassess every 5 minutes for unstable patients, every 15 minutes for stable patients, and continue to evaluate the airway. Talk with them, keep them talking, or if they aren't talking, then we need to watch that airway closely. We should, at this point, understand the 5 minutes and 15-minute rule, stable and unstable patients for vitals. Chemical burns, the longer a chemical is in contact with the skin, the greater their potential for injury. So we want to make sure that we're understanding that the chemical that's on is going to begin its process of burning. So how long has it been on? We need to get it off as quickly as possible. Has it activated or not? If it has not activated, there's things we need to do before we add water to that chemical off. Some ideas or some examples of chemical burns to the face and ear here, as you can see. Chemical burns to the palm of the hand. I had this happen to me in the emergency room. This exact injury right here to the tips of my fingers. One of our pulse oximeters, I had to actually the batteries weren't any good, so I replaced them. And when I popped the battery out, I guess I didn't recognize that the battery was already leaking inside. So I replaced the batteries, put the pulse ox back into use, and went about my day. And it was not even more than 10 minutes later, tip of my fingers burning. It hurts, and I couldn't figure out why. And I washed my hands a few times, and it just kept hurting and hurting. And I finally look over, and I have on the tip of my finger this white pad swollen. It took a good hour to figure out that I had battery acid burning through my skin. Nothing I could do about it. I've already washed everything off. It's just going to go through its process. But this is painful. This is not a nice thing. Chemical burns. Protect yourself first. Brush away dry chemicals before flushing with water. The most chemicals flush with copious amounts of water for most chemicals. Flush with copious amounts. Dry chemical not burning. Don't wash it off yet. Brush off, as it says here, the most you can. Then use water to wash the rest off. First and foremost, we understand this. We've got to take care of ourselves first. Make sure we are protected always. If that dry chemical is on the body and the patient states it is burning, don't worry about brushing it off. Just start washing it off. And there's an example right there. Take care of you first. This patient probably, or excuse me, this EMT probably could use some gloves and goggles possibly to get this done. Washing out your eyes. I'm going to tell you guys, this is a hard thing to do. When their eyes are burning, they are not open and easy to open. They are hard. They're tearing up constantly. Your hands with all the water, trying to hold their eyes open is really hard. I actually created, me and my partner years ago, working around with or messing around with some different ideas, came up with a large bag IV. I think I've talked about this before. A large bag IV with that IV tubing. There's a little roll lock or a slide lock to stop the fluid from flowing through. Slide that up as high as you can up onto the IV tubing, cut it below that, take a nasal cannula, cut that short. The nasal cannula is the two tubes that go in your nose, wraps around your ears under your chin. Cut that line short. The two lines splice together. They fit perfectly together. Okay. Then you take the nasal cannula, you set it right across the bridge of the eyes, where the nasal cannulas are actually sitting right here on either side of the bridge of the nose. What this allows you to do is now open up the slide lock with the IV hanging above you in the ambulance, and you now have two free hands to forcefully open the eyes and let fluid drain on both sides if necessary. Works great. As I talked about, or we've discussed a little bit, should understand electrical burns. We're looking at pathway. Electricity wants to find the ground. It wants to travel back to the ground is what it's looking for. And so, in this respect, we have to look for two things. We look for an entry wound. We look for an exit wound, just like a gunshot. The entry wound here is going to be a burn, in this case, to the palm of her hand. And this decided to travel the path across her heart and out the opposite foot, which then is going to be more of an explosive injury in some case, depending on the energy that's traveling through. But you're going to have a larger wound on the other side as energy exits the body. Why it takes this path and ends up on this foot, I don't know. No rhyme or reason sometimes to some things. The reality is we can actually hit, if this was to come down this arm and straight down to the opposite, the same side foot, then we may bypass the heart and have no real issues here. But here's something you need to look at, okay? Where did it enter? Where did it exit? And could it have gone through any vital organ? Electrical burns damage is caused by heat. Electrical impulse into the body can be disrupted, and things are going to kind of impede it from traveling through completely. So there you go. This is an entry wound and an exit wound. Not a lot of electricity coming through here, but it's enough to cause some problems. It's smaller here and larger here. And as you can see, he touched a wire with his forearm on the ground. It traveled probably across his shoulders back out the other side of the arm. So there you go. Electrical burn from a child chewing on a wire. Okay. I don't know how bad this injury overall could have been for this kid, but you can see the burns to his lips. Pretty nasty stuff. Here is a lightning injury. This is crazy. Lightning bolt striking a patient. I'm sure there's more than just the hand that we're dealing with here. And another lightning injury, just some redness to the skin. Can't really tell you exactly what happened here, but this is a burn to the body as well. Electrical burns, scene safety is crucial. Always assume the power source is still active unless the power company has confirmed otherwise. We need power company there to shut things down. Do not attempt to remove the patient from the source unless you are trained to do so. We should not be there. It is not our job to rescue anybody from, down power lines and that kind of stuff. We need people there to shut the power down. The fire department goes in to pull them out. Do not touch a patient still in contact with the source. Maintain an airway. Provide positive pressure ventilation if respirations are inadequate. Administer oxygen supply. Administer supplemental oxygen if indicated. Electrical burns. Be prepared for cardiac arrest. Assess for muscle tenderness. Assess for entrance and exit wounds I was discussing, and transport as soon as possible. Always keep yourself safe, okay? Because these electrocutions, they're not completely done, okay? The patient may have been thrown from it, but that electrical outlet, that source may still be active, and you don't know where it's at. So please be careful when you're near these things. Okay, so chapter 29, which is burns, is done. I've posted some worksheets. I'm going to probably add one more piece to that worksheet later. I have added the case study, which is open for you guys to review and answer questions on. Again, I don't have a lot of people putting information in there. I'd like to see some more individuals coming and reading that case study and giving me your thoughts. And I'll answer you back as that happens. I'll repost that again today with this video. And we have our test on Thursday for chapter 28, if I'm correct. Test on 28, yes, okay. That's it, guys. I appreciate all your effort. I know this is odd and weird, but thank you for everything you do, and we're going to get through this.